Welcome back. So we've just seen how to support the posterior leaflet with a resection, but when the support structures are insufficient, to add a neocord. There are two schools of thought on how to manage posterior leaflet disease. One is the resect technique, and one is what's called the respect technique, where we utilize only neocords. But we know that every patient's a little different, and we have to have tools in our toolbox or armamentarium to adapt to the situation, so we tailor our operation to fit the patient. So in situations where you have posterior leaflet prolapse and perhaps risks of systolic anterior motion or SAM, where we do have to decrease the posterior leaflet height, but we don't necessarily need to do a full sliding valvuloplasty, we want to present a technique that we call respectful resection, which is a blend of both techniques that allow us to achieve the goal of augmenting the zone of coaptation and decreasing the posterior leaflet height in the setting of prolapse without necessarily needing to complete a full sliding valvuloplasty. Let's take a look. Building upon previous experiences, we must always attempt to tailor the repair to fit the pathology of the patient. As we can see, this patient has bileaflet prolapse, predominantly posterior leaflet, with a tall posterior leaflet and preoperative imaging that predicted systolic anterior motion. So, to decrease the posterior leaflet height, we first started with a triangular resection. And there's two schools of thought. One is a resection technique, and one is a neocord, or what has been coined by Patrick Perrier as the respect technique. Now, both have positives and negatives, or pros and cons. The challenge with some of the non-resectional technique is that there's chordal elongation that it can occur late, but in specific patient populations. Otherwise, it's an excellent approach. In this case, we're combining techniques by first resection and then neochordal support in a technique we coined many years ago as the respectful resection technique. What is first involved is the proper debulking of the posterior leaflet in a triangular resection fashion, resecting of the secondary and tertiary chordal areas that might cause it to continue its height or bulk, and then using a Gore-Tex suture or polytetrafluoroethylene. Again, this is CV4, with one limb through the P1 side and one limb through the P3 side. Now, once those two sutures are placed, instead of doing a double loop technique, we can just create an anastomosis, if you will. And this method allows it either tied or untied for this to come together and use this first layer as the initial valvuloplasty, and then approach the second layer as a way of reducing the height, and with each ensuing bite as a second layer, we can make some finer adjustments until completion. Now, this technique can be applied through a sternotomy, but also robotically quite readily. That achieves two goals. It does posterior leaflet height reduction without the need of a sliding valvuloplasty. Once this is secured, we'll reassess the anterior leaflet. You may have observed when we tested a moment ago that there was still some restriction, and this is fairly common, that the secondary cord groups cause some degree of restriction, limiting the unfurling of the anterior leaflet. So this is the first time we'll demonstrate anterior secondary cord cutting when necessary. Now the valve is tested, true-sized annuloplasty has been performed, and we have excellent coaptation without systolic anterior motion. This is another example where we have bileaflet disease with bileaflet prolapse, but the posterior leaflet has a flail. The anterior leaflet is not overly long in this case. There's not systolic anterior motion risk, or very minimal, but the anterior leaflet is not robust. So how do we address this? Well, traditional resection techniques or neocord techniques would cause the posterior leaflet to be anchored low. However, you can see here that there is some mild mitral annular calcification at the base of P1 and P2, making this slightly more complicated, as you can see there. So the flail segment requires some form of reanastomosis, and we've elected to do the same respectful technique. Essentially, this is just chordal, but minimal to no resection there, already performed. And then taking these two limbs and simply putting a simple knot, a simple throw. Then using each of the two limbs to perform the valvular anastomosis. And running it in 2 layers. The one limb we can hold up with the dual blade to stretch out the tissues, which I'll demonstrate after the first bite, as noted here. And then the reanastomosis is done in a stepwise fashion. And this avoids significant resection at the base of the annulus where we know mitral annular calcification exists. And as part of this second layer, one can reduce the posterior leaflet and assess height as you go along. Now, as you can probably appreciate, we've addressed the main lesion, but there seems to be still some existing myxomatous degeneration in the posterior area, particularly around P2 and P3, as demonstrated over here. Now, largely P2, P3. So we've secured this pathology. Now let's go and address it on the opposing papillary muscle group. So it's very important to put cords that align with the leaflet with the papillary muscle, ipsilaterally. You never want to put a Gore-Tex cord, for example, to fix a P3 lesion in the anteromedial papillary muscle head, because that can cause scissoring. Here is just a simple double loop technique, which we've demonstrated before, and reducing the leaflet. And then once that's reduced, we can pull up the sutures and it locks in place. We often test the valve multiple times throughout the case, and this is the beauty of the dynamic dual blade retractor, because it allows you to turn off the root vent and test the valve multiple times so you can really be precise in what you need. So now we've demonstrated, even with mitral annular calcification in place, we can navigate this. But we need to have that anterior leaflet, which we knew was not overly robust, to unfurl a little better. And so this big, robust secondary cord that's not really contributing, we've decided to divide. This is then secured after finalizing the height and using a simple cardinal suture, drop the knot towers as we've demonstrated before, and then now test robustly and place a flexible band. And this is a 42 millimeter band, so very large, resulting in an excellent coaptation with good anterior posterior leaflet ratios and very good depth of coaptation for a durable repair. So now we've seen how to do respectful resection as a potential option where you don't necessarily have enough pathology or need to do a full sliding valvuloplasty. Remember, these are techniques that we're showing, while done robotically, are applicable to even open surgery. Now, what happens when the pathology is not posterior leaflet or anterior leaflet, but commissural at the trigones? Join us in our next episode where we'll see how to address commissural prolapse or flail.